attitude, and skills. During the year, we will continue to work on this, and today's seminar will provide you the basic knowledge which will help you change your attitude towards knee conservation, and which we will follow in the second and third webinar by techniques of surgery. And in the last, on 13th December, we'll have the pre-conference workshop. During course of the year, we'll be giving lectures on demand, hands-on workshop, planning of osteotomy, sawbone exercises, and video presentation. You will be happy to know that we'll be doing a live demonstration in Kanpur as our first face-to-face activity. All of you can join me, reach to me so that we can help you plan activity in your area. The problem is quite large. We have 46 million patients who have the need to sit cross-legged and squat on the floor. And unfortunately, we are quite low in the healthcare index. So we have to look for solutions which last lifetime for a patient, and it should be provided early. The present situation is that we know as Indians, we are more tolerant to pain. Patients don't consult us till the VAS is above 3. This leads to advanced disease, and inherently we advise surgery. We avoid surgery by habit and for financial reasons. And unfortunately, knee surgery is synonymous to knee replacement, and there are very few surgeons who do osteotomy around the knee. And thus the solution lies in teaching doctors and patients about knee conservation. A word of caution here: the industry is trying to propagate even UKA as a preserving surgery. And the other thing is that we have to understand the difference between various types of osteotomies. Open wedge high tibial osteotomy is different than STO. It's a type of STO. But when we talk of specifics, we must be clear what we are talking. And for this task, for the first webinar, we have Professor Mittal from All India Institute. He has keen interest in knee conservation. He'll be speaking on his history of osteotomy. Then we have Dr. Sen. He's immediate past president of IOA. He is known for his pelvic acetabular work, but he is very fond of knee conservation, and his talk would give you new dimensions in the lifestyle modification and exercise to conserve the knee. Then we have Dr. Ajit Saigal from Varanasi. He is a member of IOA Knee Preservation Committee, and he'll be speaking on intra-articular injections. What is the evidence? For against, we have Milind from Gurgaon. Then we have Dr. Krishna Kumar. He will be speaking on the success story of STO. And in the end, we have Dr. Dinesh Thakkar from Ahmedabad, who will tell us about what are the various types of osteotomies. And to supervise and guide us through this, we have Dr. Mangal Parihar from Mumbai. And my own personal interest is only propagating knee preservation in India and neighboring countries, so that the joint replacement, when it's not needed, is not done. And then I request our President-elect, Dr. Ram Chadha, to give us a word of wisdom. Dr. Ram Chadha.
Good evening, everybody. At the outset, may I congratulate the IOA Knee Preservation Subcommittee, headed by Dr. Sanjai Rastogi, and having very eminent contributors in Dr. Dinesh Thakkar, Dr. Ajit Saigal, and an advisor in Dr. Mangal Parihar, for having got together stage one of what Dr. Rastogi shared. He shared that there is knowledge, there is attitude, and there is skill. What he meant is we have to use our head, our heart, and our hands. He is going to address all three, दिमाग, दिल और देह. इन तीनों का इस्तेमाल करेंगे. That's the time that we'll know which patient needs what. The Lord Almighty created our entire anatomy to be preserved. And as far as possible, I repeat the words, as far as possible, we should try and preserve the creation of the Creator. So I thank you all to work towards what may not be techno-savvy, what may not be market-driven, but which comes from your heart and head and is executed by your hands. So we are extremely happy that the IOA has this active subcommittee which is working towards propagating knee preservation, not just in India, but probably the entire Indian subcontinent. So all the best to all of you. And I would be happy that my dear colleagues from the IOA who are with me, Dr. Naveen Thakkar, and of course, your panelist, our immediate past president, Dr. Ramesh Sen, would enlighten us further and take us forward. Thank you very much and congratulations to the subcommittee. Thank you so much. God bless you.
Thank you, Dr. Chadha, for your very kind words. It means a lot to us. And now I request Dr. Ravi Mittal to speak on review of literature, what the literature says.
Can I share the screen?
Yes.
Dr. Rastogi, can I leave the... Hello.
Thank you so very much, Dr. Naveen, for your presence. I am sure you will look towards the cause for knee preservation in India.
Yes, sir. Yes, sir.
Thank you very much.
Last year also, you contributed a lot for a
Yes.
knee preservation with Dinesh Thakkar and all Mangal, Parihar, and everybody has worked very hard as
Right.
far as the knee preservation is concerned. And you visited twice Ahmedabad for knee preservation workshops and live surgery.
Yes.
And the originator himself, Stobly, came to demonstrate us the STO, open wedge osteo. So I wish a great success to this webinar.
Thank you so very
And
much.
move ahead with the academics. We do not want to waste much time. Okay. Thank you.
Thank you very much.
Good evening, everybody. I thank IOA for this invitation, and I'll be talking about a review of literature regarding the high tubular osteotomy. The aim to review literature regarding HTO is to prove its efficacy, safety, and good long-term results, and also to bust the myths and false propaganda around the high tubular osteotomy procedure. Now, the first myth is that HTO is a stopgap arrangement. Ultimately, it has to go for TKR. Strictly speaking, yes, it is a stopgap arrangement, but this time gap is long enough when the procedure is done accurately, and it is long enough to avoid TKR later in life. Even the procedure of unicondylar replacement and total knee replacement do not last forever. Strictly speaking, they are also stopgap arrangements for the patient, but nobody asked this question for the knee replacement. It is asked only for the high tubular osteotomy. If you look at the literature, Cochino came up with the success of 97% at 7 years, 95 at 10 years, 87 at 15 years. Another report, 97% success 10 years, 90% at 15 years. Another report, 94% at 5 years, 80% at 10 years, 65% at 15 years, and 54% at 18 years. Another report 65 to 74% at 10 years. So this procedure lasts quite long to benefit the patient. This is a report which says that the survival rate of medial opening wedge high tibial osteotomy is 95% at 12 years after the procedure. The success rate of closed wedge STO is 92.5% at 15 years. And the overall survival rates of STO are 99% at 5 years, 94% at 10 years, and 85 at 15 years. So that's a good survival rate. Another myth is that high tibial osteotomy is unsuitable for bone-on-bone lesion. But Koshino has shown that the STO can be done for this procedure, this situation where there is bone-on-bone, which is also called a kissing lesion, and even the cartilage regenerates in the medial compartment, both on the tibial and the medial side. In this report, the authors have shown that high tibial osteotomy is a good option for osteoarthritis with kissing lesions. Kissing lesion is bone-on-bone lesions. And this report shows that the high tibial osteotomy is a good alternative to unicondylar replacement for medial compartment osteoarthritis accompanied by kissing lesions. Another myth is that HTO is not suitable in old age, but literature has shown that the age of the patient does not have to be taken into consideration for the indication of HTO. This report in 2017 showed that the age did not influence the clinical and radiological outcome after open wedge high tibial osteotomy, where the two groups of the patient were divided by age. Group 1 was A was more than 65 and group B was less than 65. The results were almost similar. Another report in 2019 that there was no significant difference in the survival rate after HTO between the two groups divided by the age. One group was less than 64 and other was more than 65. Another myth is that high tibial osteotomy compromises future TKR. The answer is a big no. There is no difference between primary TKR and TKR after HTO, and there are multiple reports to support that. In fact, a TKR is made easier when the varus deformity is corrected, and you don't have to correct the deformity during the TKR. So I have taken out few reports which show that the TKR after HTO has similar outcome as primary TKR, and there is no negative influence of HTO on future TKR. The second report says that the HTO was not determined for first worse results after TKR. The third report says that both the closed wedge and the open wedge had similar clinical radiological outcome after TKR, but there was some surgical issues after closed wedge TKR, closed wedge HTO when the TKR was done in these cases. Some people say that bilateral HTO is not possible, like you do a bilateral knee replacement, but it has been shown that you can safely do a bilateral HTO. The only thing is that these patients might need a blood transfusion when you do a bilateral surgery. Another concern is that HTO can cause patellofemoral problems, but it has been shown that despite the patella infera in open wedge HTO, there is no clinical or radiological changes in the patellofemoral joint. Some people also said that the HTO is very unpredictable. You don't know who will benefit after HTO and who will not. So first of all, this premise is false. Other thing is that if you want to be sure, you can use a temporary unloading valgus producing knee brace. And if the patient benefits with this brace, then most likely the HTO will give you a good result. So you can be sure before doing a surgery. Another concern that was raised earlier in the introduction was that the UKR is much better than HTO for medial compartment osteoarthritis. If you look at the literature, the early reports showed that the HTO was not inferior, but the later reports, which is more recent, show that the HTO is even better than the UKR. So let's see that. So this is in the Journal of Arthroplasty, a systematic review and meta-analysis. There is no difference in the functional result of the two procedures. There is no difference in the survival. On the contrary, HTO has better range of motion. Another report, Journal of Arthroplasty, meta-analysis, no difference in the specific knee scores between the two procedures, no difference in the complication and the rates of revision. On the contrary, range of motion is better in HTO. Journal of Arthroplasty meta-analysis, they concluded that the correct patient selection both HTO and UKR show effective and reliable results. Another report, Journal of Arthroplasty, that there is no difference between UKR and HTO in return to recreational activities and short-term clinical outcome. Cochrane database again says there is no difference in the pain, function, and gait after the two procedures. This is a meta-analysis and systematic review, and it concluded that they were unable to conclude which method is superior, HTO or UKR. This report that there is no difference at 12 and 24 months between the UKR and HTO. The HTO has better correction of mechanical access, and HTO is the treatment of choice for younger and active patients. Now, this is quite interesting. This report shows that the median time to return to previous professional occupation is shorter in HTO as compared to UKR, and the mean time to return to sports activities is again shorter in HTO as compared to UKR. So the UKR scores in all the aspects over UKR. HTO scores better. Now, if you see a very recent report, it looks at the rate of conversion to TKR after both the procedures. They found that the HTO was converted to TKR later than the UKR to TKR. So the survival of HTO was longer than that of UKR. Second point, the authors concluded that the HTO patients use opioids for a shorter duration as compared to those of UKR. So you have a longer survivorship of HTO as compared to UKR as per this report. Now, this is a report which says that the TKR after HTO has a lower risk of revision than TKR after UKR. That means there is less failure of TKR in HTO than a TKR which is done after UKR. So the red line shows the survival of TKR after HTO, and the blue line shows the TKR after unicondylar replacement. So the survival of the red one, which is the TKR after HTO, is much higher. Now, this is a very recent report where they compared two groups of patients, and these were all young active patients. They were not old and debilitated patients. In one group, they did a HTO and then did a TKR when it failed. And in other group, they did a TKR as a primary procedure. So what they found was that the HTO, which is followed by TKR, had better survivorship than primary TKR in young patients. So the blue line shows the survivorship of HTO plus TKR, and the red line shows the survivorship of primary TKR. So obviously there is a big difference between the two survivorship. So it concludes, in other words, that there is less failure of TKR after HTO than primary TKR in young patients. So to conclude, all myths have been busted, and we conclude that the HTO is a reliable, predictable procedure with good long-term results. It is suitable even for bone-on-bone lesions. So the myth which has been spread that HTO is not good for bone-on-bone is false. Age is not a limiting factor. It does not cause patellofemoral problems. It does not compromise future TKR. Bilateral HTO can be done at the same setting, and it scores over UKR in all the aspects. And these things can be returned to early function, survivorship, and long-term function. And when you do TKR after HTO, it has a better survivorship than when you do a TKR after UKR. And TKR after HTO has better survivorship than primary TKR in young patients. So to conclude, HTO is a very good procedure, and that can be a better solution for medial compartment osteoarthritis in all the age groups. Thank you very much.
Thank you, Professor Mittal. You have very convincingly conveyed the importance of STO. And if there are any questions,
can I ask a question, sir?
Please.
In review of literature, Dr. Ravi Mittal said that even after UKR, sports is allowed. I am not aware about that.
Sports.
What you have stated in one statement.
Return to sports, yes. But
is it allowed after UKR? I don't know exactly.
I don't know UKR, so I cannot say, but the literature is commenting on this issue.
Okay.
This must be one study, because everywhere they say if the patient has to be active, then UKR and TKR are both out. So any patient, irrespective of age, who want to be remain physically active, the only choice is doing a STO.
If you talk to people who are doing UKR, they say yes, but you have to take it with a pinch of salt.
So whatever the literature says or the primary indication, then
so this is the literature that I have quoted.
Yes. Because
Now,
you once has different type of studies. Now, recently you have also shown that article in which they say the UKA is a knee conservation surgery. So they don't agree to call it to a partial replacement. So it's only a promotional gimmick, and we should not be taken away by their statements.
See, if you look at the long-term outcome of UKR, only the center which has developed the prosthesis has got good results. Not everybody has got good results. If you look at the number of UKRs being done in UK, it is far, far less than the TKR. If the country of origin of UKR is not doing UKR, then there must be something wrong with it. So if a procedure is showing very good results only in the hands of its inventor or the patent holders, then you have to think many times before advocating this procedure.
You are absolutely right. In Australia, the indications, the percentage of people who are offered UKR is gradually going down over the last 10 years.
Yeah.
So now we move on to if there are no further questions, we move on to the next. And I will request Dr. Ramesh Sen to tell us about the role of lifestyle modification and exercise. And to my mind, this is the most important aspect, because if we advise patients these two things, then we can also delay the STO procedure for quite some time. And this will ultimately help patient in his long life.
So good evening, friends. Thank you, Dr. Sanjai. I mean, definitely you must speak what you practice. And frankly, for my own profession, in my own practice, this is what I do, followed by HTO and then TKR. Somehow I don't do uni. So incidentally, when you say to talk about lifestyle modification, this is something which I keep on telling my patients as my first management. As you have given a data that this is one of the most common problem, we understand it. So when we look at the lifestyle, we need to look at it. What are the profile of these patients who get knee osteoarthritis? Same with the literature, and which is all the latest literature available. Women are more important. We all know it from our clinical work also, but the statistical work also says the cause could be multifactorial. It's not only the gender, it could be hormonal, metabolic, structural. But do they say that cartilage loss is higher rate in women? And that's what they say, that probably estrogen replacement may help in that scenario. Then you look at the other perspective, though the title of the article is different, but the important thing which they have given is, if you look at the education of the patients, it is the low education people who have got more knee issues. Then obesity, we all understand why it is so. Type 2 diabetes have significantly more. And then sports and squatting and kneeling. These are the activities more likely to get in patients who are clinically symptomatic. A very common thing which is perceived by the people is the sports active that people are more likely to have. The literature has clearly defined it out that routine sports do not lead to higher OA chances. It is only the soccer, long distance running, competitive weightlifting, and wrestling, where there is a high contact and high collision sports. These are which have been found to be linked with arthritis. Routine sports are not linked with the arthritis. Occupation, yes. If you look at white collar job, they are least involved. If you look at the pink collar service and sales workers, they also don't have it. But blue collars, like technician, machine operators, or low-level laborers working in the agricultures are more likely to have knee symptomatology. So one may combine many factors, but this is what the paper says about from the Korean studies. Again, another question is the diet? The only thing which they have found in the diet is alcohol. Alcohol as a factor, if it is significantly related to the osteoarthritis. While the paper itself does say that high intake of full fat dairy and cheese is associated with lower chances of knee arthritis. What I am subsequently saying about this, most of these are from the recommendation, the guidelines. I am quoting less of the paperwork. I am quoting more from the guidelines, because papers may be biased at many levels. Guidelines make a very uniformity in the opinions. So when we look at these, there are some papers also where we have, I could not get specifically for dietary supplements, there is no significantly proven way that this is really good. Supplement, they say, may have some effect, but long-term follow-ups are not there, and no clinically importance has been given to dietary supplements as such. As far as management is concerned, they do say that we should reduce plasma cholesterol by dietary means. They do say that we should have more increase of 3 fatty acids, preferably by eating fish twice a week. We must have more vitamin K intake by eating green leafy vegetables. We must have safe level of vitamin D by having a better sun exposure. These are the things. The question comes, what about the vitamin D supplementation? Should it be a regular thing or? They do find it out. One of the papers have found it out. Yes, that is, there is a positive clinical effect on pain modification. But the results are still conflicting. You cannot really make a foolproof opinion. But what is clear and which doesn't require any evidence is the body weight role. Because we know that when we are walking on a level ground also, at every step we are putting 1.5 times body weight on our each knee. And when we are going up and down, the load may become 2 to 3 times and 4 to 5 times during our squatting position. When we come to the lifestyle change, obviously the first change must be in the management of the weight. And it has been seen that even if we reduce 1 kg of weight, it will have quadruple reduction in the forces which are acting on the knee joint. And the symptomatology sometimes can be ameliorated if we are doing this weight loss primarily. These are the Singapore guidelines which say that if you have a patient whose body mass index is more than 25 kg per square meter, he must follow that weight reduction protocol. But if his body mass index is more than 30, it has to be a medically supervised weight reduction program to be effective for the OA. As far as ORC guidelines are concerned, they say weight loss of 5% if achieved within 20 weeks period, meaning by 0.25% per week, is efficacious. And whatever the level of osteoarthritis, whether it is mono joint, whether it is multiple joint, this is the most appropriate treatment. Again, another paper, 2019 guidelines, again say weight loss is strongly recommended. And any step up in the weight loss, whether it is 5 to 10% stage, 10 to 20%, will definitely have an effect on the body weight, including the exercise program. And now, what are the exercises? The Cochrane review is very clear, and then you have an opinion from American Academy guidelines, ULR guidelines, ORC guidelines, that there is a benefit. It may be long-term, it may be short-term, but definitely the exercise schedules helps. As for lifestyle change, obviously exercise must be a part of it. That healthy weight maintenance exercises, at least every week, scheduled properly, must be made in addition to whatever supplements we are taking. Again, this is a 60 trials. When they were making this paper, they took 60 trials of the 44 for knee, 2 for hips, and 40 mixed. And what they concluded, that there is sufficient evidence that significant benefit occurs from the exercise over no exercise. and exercises must be combined to have strength, flexibility, and aerobic capacity. A very common example of exercise people use is cycling. Yes, cycling is definitely recommended, performed site of exercise. And then there is a level of MICT protocol, moderate intensity continuous training, or a high intensity interval training. Both are important for having an exercise. A very common thing in our Indian population is to know about yoga. Because the way we sit in yoga, it is likely to produce a strain on the medial side. But what is said in the scientific paper is that if you have to do yoga, you can do. The only thing is you must have reasonable amount of external rotation, not on the knee joint, but on the hip joint, which one can practice. And if it does that, there is not much strain over the knee joint. And then if you look at the benefit of that yoga, there are reasonable number of papers published, which they say it has got a positive effect on the knee issues, and improved pain, knee symptom, and strength can happen. All these studies say. The routine physical activity, the literature is very clear. Activity which has got more than 10,000 steps is okay, but if it is less than 10,000, it is likely that OA can be accelerated, but not a very significant advance. But what they say, at least 45 minutes can improve or sustain normal functional activity in prevention of the lower extremity osteoarthritis. Whether the use of cane in that age group can help, yes, it can diminish pain, and sometimes it can increase the ability. But same is not about crutches, because our ORC guideline says they are very unclear whether the crutches should be given to a patient who is symptomatic or not. Braces, there is a controversy. There is a recommendation from Cochrane that it might increase the walking distance, but American Academy says we are unable to recommend for or against. The 2020 guidelines say they may have some kind of effect, but not much proof can be added to. A very simple thing is a sole. What is the kind of a shoe? And the recommendation is flexible soles, like flat walking soles, and which put less stress, a flexible rubber sole. And they say this is appropriate. ORC guidelines says for every level of OA, this is an appropriate change. Our seniors very many times were advising a lateral wedge insole in a way to reduce the pressure on the medial side. Incidentally, I had my own patient who came after a year with a follow-up when she showed her previous X-ray and the sole which she was using and the X-ray in the day of that day. So there was a significant improved with that kind of effect, which surgery was to produce later on. But here, just that my query was what you did for the whole year, that I kept on using these kind of a sleeper for whole of the year. So meaning by this mechanical alteration does have that kind of benefit, if not in all, but at least some patients over there. Among the thermal interventions, yes, our guidelines suggest diathermy, ultrasound, hot and cold packs. Hot packs have little doubtful about a tri-space massage, and they do feel it has got a beneficial effect. Some people, maybe the Cochrane review says, some people may have some kind of a benefit, but overall the evidence is not very high. A very simple things come topical NSAIDs. If there is single joint involvement with or without comorbidities, they are okay. They are safer, they are better. But question comes, which one is better? This is one study now, which says the diclofenac is most effective for topical pain relief. And if we want to improve function, piroxicam, but avoid salicylates gels. So overall, when you are looking at osteoarthritis, the ORC guideline says topical are strongly recommended, and it might take about 12 weeks for that to be effective, but we are happy that it doesn't have a lot of comorbidities. So when we overview the management, all these greens, meaning by exercise, weight loss, self-management program, Tai Chi, yoga, or cane and braces are all in green, meaning by they are strongly recommended. And there are some others, hand orthosis, hand this, they are conditionally. And what is strongly against is something like TENS also. And then there may be no recommendations for some. Then the question is, do the patients follow our guidelines? Whatever the guidelines are given, the literature, if you can look at that study, only 20% of the participants are using. Not very many people abide by what is said. And then the same paper further says, who are the people who are not likely to accept these lifestyle modifications? Are our older participants, patients who are not very well educated, who are less than post-secondary education, and females. These are the people who are not likely to understand the guidelines of so-called lifestyle modifications and likely to go. And what happens? Most of these patients actually end up in a replacement which is not appropriate. It has been found it out in USA study that 26% of the TKR were performed when they were done prematurely. Either the patients were younger or they were living alone and they had economic necessities. So to sum up, the practice which is going on, that the healthcare providers passively await the final joint death so that they can do a replacement, that's not appropriate. We must appreciate osteoarthritis is a chronic condition where there is always a chance of a prevention, and there are proper norms, the proper model which can follow. We understand that joint injury, obesity, and impaired muscle functions are all modifiable things. They are all amenable to primary and secondary prevention strategies. So we must choose the right interventions, which is acceptable to our specific patient to maximize the adherence and persistence with the regime. Because now it is the time we must make an effort of personalized prevention of knee osteoarthritis. Thank you. Dr. Sanjai, you are muted, please.
The way you convince your patients. If there are any questions from the
Sir, I
audience.
have a small doubt regarding this.
Please.
There are a lot of patients with osteoarthritis who come and ask us regarding the use of hot versus cold compresses in the knee. Of when to use the hot and when to use the cold compresses. Sir, your take on this, please.
Yes, this is a very common question. I understand. I tell to the patients, each person has got its own modality. You can try both. Mostly we have seen the cold is better, but have your own perception, because you cannot have a generalized thing for A, B, C, D and everybody. Let him adjust with both, find it out which is good for him and use that. That's my practice.
Right, sir. Thank you, sir.
I strongly agree with this. The way I would do it, because the patient comes to you when there's an increase in pain of a short duration. So start with cold. He would be benefited. If he says no, then you can always tell him that you do what suits you better.
Sir, another thing that I would like to ask sir is, Ramesh sir, is regarding the use of braces, sir. There are a lot of patients who have an acute exacerbation of a chronic pain in the knee. And probably we take it as probably a degenerative meniscal tear or sudden aggravation because of an abrupt movement or a twisting movement or an uneven surface that the patient walks on. But is use of a brace actually helpful in all the patients, or do we have some criteria to use these braces in selected patients?
Yes, there are two things here. One is the question of acute exacerbations, and second is the braces. As for acute exacerbation, they can happen, as you rightly said it out. Sometime there will be mechanical tears happening in a degenerated joint. They need to be treated as an acute phase of a synovitis in an arthritic joint. This is likely to settle down with some days rest until inflammatory and something like that. And then in my practice, I put them on a gradual physical therapy. The braces are specifically, I don't use them so often for two reasons. They are cumbersome to use, and patients are never comfortable using them. And they are costly also for our population. If you're looking for a good brace, they are not very economic also. So I don't reasonably use it. There will be patients who will be coming with braces. I do ask them, are you comfortable with it? Who have been advised elsewhere also. Some patients do feel, but some patients say, nahi, ab ye chubta hai, this doesn't go very well with me. So personally, I'm not a fan of using braces, but I do see some patients iske ji kuch fark pada hai, but I have not found in my own clinical practice a reasonable benefit out of it.
One
Sir,
question, Dr. Singh.
Please.
Sorry.
one question, sir. So you talked about, you just now mentioned about braces. Does the long-term use of a brace affect the quadriceps power? Because quadriceps power, once it is reduced, it's likely to increase the osteoarthritis, right?
That exactly, I mean, the literature is very clear, and I have shown you 3 different things. Cochrane reviews, somewhere it says, American Academy says we cannot say this way or that way. And other literature, I have not been able to find any guideline which says it should be used. They say it has got a variable effect depending upon the studies which have been conducted. Personally, I feel the quadriceps stents are much more important than having a passive support in the form of a brace. So active work of the patient, if it is made, is much better. And if you are using a brace as a passive support, it will definitely enable. So what I tell to the patient, that if you are comfortable, please get more exercise. Just like for my back pain also, if somebody is using a back pain belt, I say now you have to do more exercises, because this belt is taking away the active forces from your side, making it passive. So your activity must not be only to use a brace, but to strengthen more. That's my take.
One question, Dr. Sen.
Please.
What form of estrogen you use for the postmenopausal ladies in cases of the osteoarthritis?
Because I don't have that profile of patients coming to see, I do not use these things. I'm more into lifestyle. This is the literature which says. I personally am not using that, so I don't know about the exact dose these things. But I'm careful about exercises, lifestyle modifications of that part.
As some of the calcium preparation, they are coming with the isoflavone, and they claim that it is a natural estrogen and that helps. It is just a claim by the company.
Yes, yes. So
I want to, what is your practical experience for this?
I only believe in guidelines which are clear. I don't have my practice based on studies. That's my take.
Right.
Thank you, Dr. Ramesh Sen. We'll move on to the next.
Can I just put in a question, a quick question for Ramesh sir? Sir, is there any role of electrotherapy in patients? Because there are a lot of patients who have written on their OPD prescriptions by many physical therapists as well as orthopedic surgeons regarding the need of settlement for acute osteoarthritic events. They prescribe few days to weeks of electrotherapy. Is it really advisable?
I never advise them. Rather, many times the patients are not happy when I say change your physiotherapist, because this is more a business actually. They take away the patient somehow. I mean, physiotherapists are never happy with me because my force is always on good exercise as a management rather than these passive things which are coming up. They are more of placebos. And if you have seen that one of my last slides, what is contraindicated are all those things.
I totally agree, Dr. Sen. I say to compete exam, self-study is more important than tuition. That's the way I tell them. So thank you very much.
Thank
now
you,
we move on to the next, and that's by Dr. Ajit Saigal, role of intra-articular injections. We are running a little late, so we have to be on time. Dr. Saigal.
Okay. The topic has, thank you, Dr. Sanjay, the chair of the Knee Preservation Committee. The topic allotted to me is the role of intra-articular injection evidence for. The intra-articular injections, they are given in form of the cortisone, viscosupplement, and PRP. Cortisone can be given 3 times, but I have come across with the patient where physicians have given 30 injections in the knee joint, and result was the Charcot's knee, as you can see. Then the PRP is the talk of town nowadays. What is the myth with PRP, whether it works or not, or how much it is effective? Coming to the history, it was firstly used in 1987 for an open heart surgery procedure for healing of the sternum wound, and then the begin of the gaining popularity in mid-90s, and now since it has been applied to many different medical fields such as cosmetic surgery, dentistry, sports medicine, pain management, and osteoarthritis. The platelet preparation, the PRP preparation, this is a normal process. The blood is collected and then centrifuged, and now it is platelet-rich plasma is extracted from the tube, and this is the centrifuge machine. This is a photo activation machine. And it is said that when you activate the plasma with the photo activator machine, it is less painful, and the alpha granules, they break fast and release the growth factors. Coming to the point, the single spin oblique double spin PRP, the single spin PRP produces a serum with a less concentration of the platelet, and dual spin it provides the approximately up to 6.7% times better. Activation, it plays an important role, whether done chemically or the photoactivation. After activation, injection is less painful and degradation of the alpha granules occurs fast, which releases the growth factors. The composition of the PRP, as you all know, these are the different growth factors and other cytokines, which include platelet-derived growth factor, transforming growth factors, fibroblast growth factor, insulin-like growth factor 1 and 2, vascular endothelial growth factor, epidermal growth factor, interleukins 8, keratinocyte growth factor, connective tissue growth factor. These are all different growth factors from the alpha granules of the PRP. And they initiate the following stage, and they do tissue necrosis resolution, they do the chemotaxis, cell regeneration, cell proliferation and migration, extracellular matrix synthesis, remodeling, angiogenesis, and epithelialization. These are the different growth factors. This is the alpha granules, which breaks and releases the growth factors. These are the different grades of the osteoarthritis, grade 1, 2, 3, and 4, as you all know. I don't have to describe it. Then PRP in knee osteoarthritis, one study was published in 2013, involved 78 patients with osteoarthritis in both knee, and each knee received one of the 3 treatment options, one PRP injection, second, and one placebo saline injection. Researchers, they evaluated the subject knee 6 weeks, 3 months, and 6 months after the injection, and knee treated with 1 or 2 injection of the PRP, they showed a reduction in the pain, stiffness, as well as improvement in the knee function at 6 weeks and 3 months. At the 6-month mark position, results, they declined, though pain and function were still better than the before PRP treatment. The group that received the placebo injection saw a small increase in pain and stiffness and a decrease in the knee function. The platelet-rich plasma used in this clinical study has 3 times the platelet concentration than the normal blood. These are the, by giving the injection into the knee joint. Our study with the 387 patients with grade 1 and 2 osteoarthritis only. At this position, I want to emphasize that technique is not bad, technician is bad, and when we use indication for our own extended indication, then the results are definitely not as expected. If it is used in grade 3 and grade 4 osteoarthritis, definitely PRP is going to do nothing. So I injected PRP at the interval of 10 days for the 3 doses and 1 injection after the 1 month. This was the protocol at the Australia from where I got the training. And in all cases, there was much improvement in clinical presentation of pain in terms of duration, intensity, and pain in the night causing major distress, swelling, stiffness, and range of the movement. In comparison with the intra-articular steroid, in 49 patients, injection Kenacort was given intra-articular. At the interval of 1 month and 3 injections were given. The effect of Kenacort was studied, and it was found that initially the pain was reduced and even the stiffness was also reduced. But the effect vanished with the time, and the patient had same symptom of pain and stiffness. And in 7 patients, there was no improvement, and all of them were strongly RA positive. Early osteoarthritis knee are the most common painful orthopedic condition treated by the orthopedic practitioner. And in this study, to assess the role of PRP injection treatment of the early osteoarthritis knee, this study started in 1960 to December 22, and all the patients were selected from grade 1 and grade 2. And in that, the Wong-Baker face pain scale was measured. Then VAS score were measured. Most of the patients were grade 2 to 5 or 6. Then the WOMAC score were included, and the swelling symptoms were swelling of the knee, clicking of the knee, catch and hang of the knee, straighten of the knee, bend of the knee, pain and stiffness, the experience of knee pain, twisting, pivoting of the knee, straightening of the knee, bending of the knee, walking on flat surface, night pain, sitting or lying, standing upright, stiffness of the knee, and lying in resting. These are the all different. And if you see the function in the daily living, so ascending a stairs, descending a stair, rising from sitting, from standing, bending to floor, these are all different daily activity where patient they have problem with the osteoarthritis. So in our protocol, the informed consent was taken, sensitivity for the local anesthetic is done, or history taken whether patient has local anesthesia in past or not. And if patient is on anticoagulant like Disprin and those drugs, they are stopped for 3 days. And all the anti-inflammatory they stopped before giving the PRP for 3 to 5 days. And patients were explained the procedure under the aseptic condition, procedure is started. The 9 ml blood withdrawn in a sterilized anticoagulant tube of 10 ml with 1 ml citrate solution. And the collected blood then centrifused with 1000 RPM for 10 minutes. From the centrifuge tube, 8 ml PRP was separated and again centrifuged for 3000 RPM for 10 minutes. The collected PRP then activated in photoactivation machine for 15 minutes to activate the growth factors. And in fully sterilized condition, patient painted, draped, and injection given in the knee joint. Our protocol is 3 injections given weekly or 10 days interval, and 1 injection given yearly. Prescription was given only for paracetamol, 650 milligram BD or TDS, SOS, quadriceps and hamstring exercises, and no anti-inflammatory type. Patients they were all followed for 12 months at 1, 3, 6, and 12 months, and results they were quite good. And in a study, PRP was significantly effective in reducing pain, improvement in the function with range of movement in early grade 1 and 2 osteoarthritis of the knee. Now, the lyophilized platelet plasma is also available on a commercial basis. There is one study in the National Institute of the Health, Maryland, USA, that MRI changes after the platelet plasma injection in knee osteoarthritis. It was a randomized clinical trial, and few papers has studied effectiveness of the PRP on cartilage. In this study, we investigated the effective of the PRP on cartilage characterized by MRI consequencing the knee osteoarthritis. In this study, in addition to effect of PRP on VAS and WOMAC score, there was significant effect on radiological characteristic patellofemoral cartilage volume and synovitis. And for further evaluation, a long study with a large sample is recommended. Result was that it is seen that in the MRI, there was thickening at the cartilage level at the end of the femur. And when it is computerized, the image was formed. You can see the difference between the before and after the PRP. The contraindications of the PRP therapy, the treatment with autologous PRP is generally considered to be safe, and hematological evaluation to rule out the potential coagulopathies and disorder of the platelet function. Patients who are anemic and those with thrombocytopenia may be unsuitable candidate for treatment with PRP. Other potential contraindications, they include hemodynamic instability, severe hypovolemia, unstable angina, sepsis, and anticoagulant or fibrinolytic drug therapy. Take-home message, the autologous PRP is a relatively new biologically compound that has shown promise in this stimulation and acceleration of the soft tissue and bone healing. The efficacy of this treatment lies in the local delivery of a wide range of the growth factors and proteins, mimicking the supporting physiological wound healing and reparative tissue process. PRP can be injected directly into the tendon, which provides healing. It's a low-cost treatment, and selection of the patient is very, very important. This is a feedback from, I will just show you the 2 patients' feedback. She is an international athlete, and PRP treatment was started in 2015. And for last 8 years, she is getting PRP very regularly. And she is doing very well in her field. she is a patient. She came today for the injection on a yearly basis. And thank you. This was the review of the patients regarding the PRP therapy. Thank you. Your mic is muted, sir. Dr. Sanjay, your mic is muted. Yes.
Dr. Milind. You can, Dr. Saigal, you can stop sharing your screen. Dr. Milind, please.
Sir, I am sharing my screen, sir.
Yes.
Sir, am I audible?
Yes. I request everybody to.
Sir, is it okay? Am I audible? Hello?
There is echo from the.
Sir, am I audible?
Sir, you are running two screens. Just come to one screen. So otherwise there is echo.
Sir, am I audible?
Yes,
Yes.
Sir, can I share my screen now?
please. You can make it full screen.
Right, sir. On it. So a special thanks to IOA committee and Dr. Mangal Parihar for support and blessings. Sir, my topic that has been given to me is viscosupplementation and where we stand today during these intra-articular injections and typically viscosupplementation. So moving forwards, viscosupplementation essentially, the viscosupplement is basically a chemical with a high molecular weight crossly high-linked hyaluronic acid, which reduces cartilage breakdown and improves endogenous hyaluronic acid production. So hyaluronic acid is basically a natural immunity to shear forces and can alter biological properties of the joint. But significantly, it plays no role in the mechanics. So what we long for in these cases is an appropriate use criteria where it has been said that it can be given in cases of early osteoarthritis and it delays total knee replacement surgery, where a few papers or literature supports that. In cases of severe osteoarthritis who are not willing for surgery, who are not fit for surgery, and who have contraindicated NSAID use, viscosupplementation, steroids, and PRP may be an option. Third indication that has been given in literature which lacks substantial evidence is post-arthroscopy debridement and young patients of early degenerative wear due to overuse. But do we actually have an appropriate use criteria in these cases of intra-articular injections? Because there is a large subset of population which is excluded because they have a significant varus and varus valgus malalignment by the time that they present to us. And there are not many patients of grade 1 and grade 2 osteoarthritis who are actually willing for an intra-articular procedure. So starting with my the evidence, I would present that osteoarthritis is actually a disease of mechanics. The most important point that Ramesh sir has also significantly highlighted, that mechanics actually plays a vital role in this. And altering biology may not be a very long-term solution without side effects in cases. Plus, in cases where an economically weaker or maybe a developing nation is concerned, where every patient cannot afford a viscosupplementation or maybe an intra-articular injection, this actually remains dubious, and the role of exercises and primary management comes into play. So I present a paper from the Indian authors, where 78 expert orthopedic surgeons have given in 2 national meetings appropriate criteria for diagnosis, patient selection, and follow-up evaluation for knee osteoarthritis, considering that in 2011 the disease burden, osteoarthritis accounted for almost half of all the chronic conditions in age more than 65 years.
मैं समझ गया, लेकिन अशोक भी नहीं मिल रहे हैं और ऋषि शायद कर रहे थे, वो भी नहीं मिल रहे हैं. I don't know. इसीलिए मैंने आपको फोन करा.
Please, Mike.
Sir, तो
नहीं पा रहा था कि स्ट्रीमिंग स्टॉप.
Dr. Rastogi, please mute your mic.
Yes, Dr. Milind.
Sir, so there is basically the problem with this is basically that we haven't been really able to understand that the mechanics play basic role, and in these cases there has been a lack of evidence, and this evidence basically says that there are no structured guidelines for giving viscosupplementation or cases where we can give PRP or steroids. So the next slide says that in this same paper of viscosupplementation, what we long for is actually the criteria for patient selection, uniformity, predictability of how long will the effect be, follow-up evaluation with compliance and cost of injection, which is included. Plus, there is paucity of strong clinical evidence, regime is not defined, and the adverse drug reactions and financial burdens are a concern. Sir, so extended indications or same indications, we are still unsure, because in viscosupplementations, patients of Kellgren-Lawrence grade 1, grade 2 osteoarthritis have been given viscosupplementation. And in these cases, there have been very unpredictable results. The second important criteria of viscosupplementation says that grade 3, grade 4 OA, which are not willing for surgery, not fit for surgery, and contraindicated use of NSAIDs can have viscosupplementation. It is not a primary line of treatment, but what else can we do? And the third subset of patient remains young patients who have sports injuries associated with minimal chondral lesions and chondropenia, and who are basically overuse athletes. Sir, the next paper that was presented in BMJ 2022, the supportive evidence of Parihar et al. Sir, am I audible?
Yes.
Okay. So the supportive evidence says that there is a small reduction in knee osteoarthritis pain as compared with the placebo, but the difference is less than minimally clinically important difference. And there is an increased risk of serious adverse events as compared to placebo, and these findings do not support broad use of viscosupplementation. So this is a 2022 paper, sir, where 4 major lessons have been drawn. The first thing that I would like to relate is that original PMA application was approved in August 8, 1997, post which there were a lot of studies which were on viscosupplementation. And despite sufficient evidence which said that viscosupplementation has no role, there were a lot of studies which were done post 2009 also. There were over 12,000 patients who were subjected to intra-articular injections, and 9 large randomized control studies were done, and they were completed after 2012. So the basic thing is that this article tells us that viscosupplementation is probably equal to or likely equal to placebo, and higher side effects are seen. Based on the data from the same paper, sir, from Medicare, expenditure on viscosupplementation treatment was expected to be about $325 million in 2018, where 28% of it, that was about $91 million, was actually spent on treating large joint infections after viscosupplementation injections. So as a developing country, where do we stand in this kind of a scenario is one doubt and a question. Also with this, we have another paper which mentions that in viscosupplementation, early osteoarthritis patients have up to 14 weeks of relief in pain, but it doesn't really change any structural component of the cartilage composition. And there is no long-term effect on the cartilage. So basically it is more like a symptomatic relief and is temporary and has no effect on long-term prognosis. Sir, now this slide that I'm presenting is how long can I expect the benefit of TriVisc to last? So this is taken from an FDA or US FDA website where the answer is very uncertain, and it says that each patient reacts differently to TriVisc, so it is not predictable. 3 injections given at weekly intervals can provide almost up to 12 weeks of pain relief, and the duration may vary. So we do not have an effect that is predictable. We do not have a time duration that is predictable. And looking at the financials of the developing country, are we really ready for it? Sir,
Dr. Milind, your slides are not moving.
Sir, is it okay?
We are seeing one slide where viscosupplementation for management of knee osteoarthritis from an Indian perspective. It has not moved from there. I don't know whether it's my network issue or is it like
it is not.
It is not moving.
Okay, sir. Let me look at it. Just a second, sir.
But you can summarize.
Just a second, sir. I am here, sir. Just a second, sir.
Dr. Milind, you were heard. You can summarize your talk or your concluding slide.
You are not audible, Dr. Milind. You are not audible. Unmute your mic. Unmute your mic.
In the meantime, if there are some questions on the intra-articular injections.
Sir, am I audible?
Yes, you are audible.
Right, sir. So I'm using another laptop here. So I just make use of this now.
Dr. Rastogi, sir.
Yes.
This is my OPD time and one patient, fracture patient is lying outside. Can I leave?
Please.
Thank you, sir. Thank you.
Sir, I'm sharing my screen.
Yes. But you should present your concluding remarks.
Right, sir. I'm just on it, sir.
Yes.
So basically, sir, what the conclusion is in the three things that we have actually seen. One is osteoarthritis, the role of intra-articular injections. One is corticosteroids, another is PRP, and the third thing is viscosupplementation. So my take on this is, since I have been given this topic, the appropriate use criteria and the rational use criteria is actually missing, and there have been a lot of studies regarding the same. So platelet-rich plasma has been a biological modality which has been in vogue and in favor. Like Saigal sir already has denoted, leukocyte-rich, platelet-rich plasma now is the most important and upcoming modality in sports persons, along with viscosupplementation. Corticosteroids basically have been a big no-no in most of the recent publications, where corticosteroids have also led to an increased risk of joint infections post replacement surgery, and they have also been denoted to have caused the periarticular osteopenia in most of these cases, and increased rate of complications post 3 to 6 injections of steroids. Sir, role of viscosupplementation is still unclear, and since it forms a major financial burden on the economics, and second thing, the recent literature also does not have a full proof regarding the efficacy and the time of relief. The patient criteria is not still confirmed. The patients who are to be counseled regarding this intervention, we cannot really do that appropriately since there is no predictability. So the most important concern here is that viscosupplementation also doesn't work in patients with mechanical malalignment, who are most commonly presenting to the outpatient department in our country. So very less patients who come in with grade 1 and grade 2, and also those who come in with grade 1 and grade 2 do not really want to be managed with interventions in the first or the second go. And most of these patients actually improve with physical therapy, as Ramesh sir has already thrown on light on.
So thank you so very much. One has to be very judicious in intra-articular injections. Maybe only athletes sometime would require and be benefited. Now we move on to the next, and we have success story of STO by Dr. Krishna Kumar.
Milind, can you stop sharing screen, please? Yeah. Milind?
Sir, I have stopped sharing the screen.
Now it's
No, it's still showing sharing screen.
Okay, sir, just give me a second.
Yeah, that's fine now. So thank you very much, IOA, for giving me this opportunity. So I would be talking about the success story of high tibial osteotomy. Objective of this talk would be to highlight on the factors contributing to the success of high tibial osteotomy. With the advent of joint replacement surgeries, high tibial osteotomy went to the backstage for probably a short period of time, and right now there is again a resurgence of osteotomy treatment for osteoarthritis of the knee. I would be highlighting on the literature review about the long-term and the medium-term success of high tibial osteotomy, and along with a little bit of my personal experience with osteotomies. I would start off with a case. This is a 55-year-old lady came with bilateral knee pain. She was referred to me in 2012. And she was already advised total knee replacement on the right side, came for high tibial osteotomy on the left side. She had bilateral varus knee, full range of movement, minimal fixed flexion deformity, and all the conservative measures were exhausted. Now that's her full-length X-ray and clinical picture. We did a high tibial osteotomy on the left side. This is in 2012. That's her function after osteotomy. That's her X-rays. And finally, she got her right knee replaced. I happened to see her 11 years post high tibial osteotomy, and 7 years after her total knee replacement. And this is what she had to tell. My right knee, that is the replaced knee, is good, but my left knee, which is the osteotomy knee, is much better. So what was the reason for a successful realignment? Number one, appropriate case selection, and the second was adequate realignment. So it all started in 1961 with Jackson and Woe starting doing an osteotomy on 8 patients for osteoarthritis knee. But most of the work in this field, early work, was done by Coventry. In his initial paper, he emphasized the results at 4 years, which was satisfactory. Later in 1984, again, he published long-term results and he said that the results deteriorated with time if the correction was inadequate. And if the correction was more than 10 degrees, that is 10 degrees of overcorrection, most of the patients did well. In 1993, he also added one more risk factor, that is overweight, and also the undercorrection. These are the 2 risk factors associated with failure of a high tibial osteotomy. So the problems with Coventry osteotomy was, it was a supratubercle osteotomy. There was alteration of patellar biomechanics. Reproducibility was an issue. It worked well with Coventry, but many other authors found it difficult to get the same amount of success. And there was a problem with the revision to knee replacement. When we consider the incidence and progression of osteoarthritis, the most important factor that decides the incidence as well as progression is alignment, which is measured on a full-length weight-bearing X-ray. When the knee is normal, 70% of the total weight is borne by the medial compartment. When it goes into varus, it becomes almost 97%. And when it is in valgus, 4 degrees of valgus, 50% is borne by each compartment. When you consider about compartment-specific osteoarthritis, malalignment is the most important factor in progression of the disease. So a lot of work has been done on alignment and osteoarthritis knee, and all these papers, they say that malalignment is the most important factor leading to progression of the disease and deformity. So basically, it means that alignment is the key factor in the onset as well as the progression of knee osteoarthritis. And this was one paper in 2001 published in JAMA, the role of knee alignment in disease progression and functional decline in osteoarthritis. And they say that in primary knee osteoarthritis, varus alignment at baseline increased the risk of subsequent progression of the arthritis, and valgus alignment increased the risk of progression of lateral compartment arthritis. So again, it becomes a vicious cycle. When there is a little bit of varus, it leads to a medial compartment osteoarthritis. And when the medial compartment arthritis progresses, the deformity again increases. So it becomes a sort of a vicious circle. Success of STO depends on realignment. And the question is how much to realign. And we all know that it is 3 to 6 degrees of mechanical valgus or a hip knee angle of 183 to 186 degrees. So the indications for high tibial osteotomy are predominantly a unicompartmental disease. It need not be a pure unicompartmental disease, but a predominantly unicompartmental disease. The other remaining things like subluxation, body weight, age, and range of movement, these were earlier considered to be contraindications, but now they are only relative contraindications. Age is a relative risk factor. There are papers which say that survival rates are more if the age is less than 50 years. But nowadays, majority of papers say that age independently is not a risk factor. Functional outcome, you get the best results when the hip knee angle is 183 to 186 degrees. These are, Hernigo et al. Had proved this, and following that, multiple papers have come out with the same findings. So the probability of survival for STO at 5, 10, and 15 years in a paper by Catherine Hui is 95, 79, and 56% respectively. Medium and long-term results of high tibial osteotomy, the functional outcome of high tibial osteotomy is progressing. And even this can be tried in patients with high degree of cartilage damage. Flockermeyer in a very large series, that is a series of 533 knees, said that this can be attempted even in patients with a high degree of cartilage damage. So the question is, here you see a patient with predominantly medial compartment arthritis, but if you watch closely, you can see that there is involvement of the slight involvement of the lateral compartment also, but he's only 58 years and he's not willing for a TKR because the lifestyle modification required for a replaced knee he is not willing to accept. So he was ready to take the so-called risk, and that's his range of movement. He has full range of movement, and that's the follow-up. And this is how he was walking earlier before the surgery was being done. You can see that there is a lateral thrust. He walks with reasonable difficulty, and after surgery, he has a reasonable good gait. And it's 2 years now since surgery, and I'm keeping a close watch on this. And he has a decent range of movement in both his knees. So high tibial osteotomy is an option in a little bit of advanced disease also, but that doesn't mean that it can be, the indications can be extended beyond a certain limit. So the success depends on cartilage regeneration at the knee joint. So as time progresses, usually the result, like probably for a year, the patient keeps on feeling improvement after high tibial osteotomy. The reason is this was proved by Cushino in his arthroscopic study that after a high tibial osteotomy, the cartilage is replaced, the cartilage regenerates, and it's a high quality fibrocartilage. It's not a hyaline cartilage, but it's a high quality fibrocartilage. So that has been proved by other authors also. So how much to correct? 3 to 6 degrees of mechanical valgus. Anything more than 6 degrees might be a little bit of detrimental effect, might have a little bit of detrimental effect. Hip knee ankle axis of 183 to 186 degrees and axis passing through the Fujisawa point. The Fujisawa point is basically the lateral border of the lateral tibial spine. And the most important part is you get an adequate correction, but along with that, you should be able to maintain the correction. So how much to realign? Hernigo again has proved that the best results happen when it is 183 to 186 degrees and there is no disease progression in this knees. More than 186 degrees correction sometimes leads to a progressive lateral compartment osteoarthritis. Accuracy of correction cartilage regeneration. The relationship was proved by Fujisawa. He said that mechanical axis passed through a point 30 to 40% lateral to the midpoint. The ulcerated region regenerates, it regenerates from the surviving cartilage along the border. And about 1 to 1.5 to 2 years after osteotomy, the ulcerated region was thoroughly covered with fibrous and membranous tissue. So cartilage regeneration is not a myth, it happens. So that is one of the edges that a fixator-assisted realignment compared to other procedure has, because the accuracy of correction can be perfect because it allows you adjustability in the post-operative period. So outcome and cartilage regeneration depends on accuracy, and that is 4 to 6 degrees of valgus. So the planning is the key to successful realignment. The success always depends on your planning. You plan with help of soft spot films and full-length radiographs. Calculate the mechanical axis deviation and also the varus. LDFA, MPTA, and joint line congruity also. Find out the apex of the deformity. And this is how you plan. The axis passes through the prospective proximal axis, which is passing through the Fujisawa point. Distal axis is projected from the ankle. You calculate the correction, and this is how the final correction is. So that's your planning. Level of osteotomy. There is something called an a la carte approach for realignment. So every varus is not treated in the same way, and every valgus is not treated in the same manner. You see 3 cases here. The first one is a varus medial compartment. All the 3 cases, in fact, are medial compartment arthritis. And this is how the deformity looks like. Number 1, it's the tibia. Second case, it's the femur. And the third is both the femur and the tibia. So the level of osteotomy is tibia in the first case. In the femur, it's diaphyseal femur, actually distal diaphysis. And the third one is distal femur and proximal tibia. So femoral osteotomy, you can add they never hesitate to add a femoral osteotomy if required. We do it when the LDFA is more than 90 degrees, and especially when the patient has a lateral thrust on walking. That doing a additional femoral osteotomy helps to avoid the joint line obliquity. You can correct the femur up to an LDFA of 85 degrees. You can see that this lady has a lateral thrust while she is walking. We did both her tibia and femur. And once the correction was done, her thrust is completely gone and she is walking comfortably. So the rationale for femoral osteotomy is poor clinical outcomes were more evident in excessive MPTA. If it is more than 95, that is overcorrection of tibia itself is detrimental. Lateral compartment pain was experienced significantly frequently in the patient who had a significantly increased MPTA following an osteotomy. But there are papers against that you can have an oblique joint line, but still the functional results are good. But as far as we are concerned, we still prefer to osteotomize the femur wherever required. Opening versus a closing wedge osteotomy, the functional results in most of the series, comparing opening as well as closing wedge osteotomy, are comparable, provided the correction is adequate. Now, a word about fixator high tibial osteotomy. This is what I usually prefer to do. You get accurate correction because you have the possibility of correcting it in the postoperative period. You have the option of taking the full length weight bearing x-rays also. Postoperative adjustability is there, and there is no change in the tibial slope or patellar biomechanics when you're doing a osteotomy distal to the tuberosity. And maintenance of correction with time is not an issue because you're using the principle of distraction osteogenesis, and more mature bone is being created, and we get excellent functional results, and we have papers from our own country highlighting these factors. And less blood loss, negligible soft tissue dissection, better healing potential because you're using the principle of distraction or osteogenesis, and there is no interference with future TKR. Patient is fully functional from the 4th week of surgery. So to conclude, the parent knee is always better than prosthetic knee. Realignment osteotomies are to be done to prevent or at least delay knee replacement, and the aim is to provide a functional and pain-free knee, which in turn rely on accuracy of correction. So alignment maintenance is the most important thing when you take the factor of long-term results in a high tibial osteotomy. And fixators and lock plates have a slight edge over other methods of fixation when you think in terms of maintaining the alignment. So every patient is to be considered as a candidate for future TKR, but the procedure should not create problems for the arthroplasty surgeon. So these are the factors that needs to be thought of when you consider the success story of high tibial osteotomy. Thank you.
Thank you, Dr. Krishna Kumar. Now, if there are any questions,
can I ask a question, sir?
please.
I want to ask a question that how long do you keep external fixator? How many weeks?
For me, it's I use these type of dynamic external fixators when I'm dealing with a deformity which is less than say 20 degrees, not more than 20 degrees. So these fixators are usually retained. Average, I would say 3.5 months, but there were situations where I have removed fixator at 3 months, and also there are situations where the healing has been slightly delayed, especially when doing these older patients, where I had to retain the fixator for 5 months.
Okay. And second thing, do you have encountered any loss of correction after removal of fixator? That is what common complications many of the surgeons are facing.
We remove the fixator. We remove the fixator only once we are sure that there is no collapse. So once we see good healing on X-rays, and when the patient is fully weight bearing, we loosen the fixator and make them do a trial walking, lock the fixator again, and send them home. Call them back again, do the trial walking once more, and then only if there is collapse more than 2 mm, we retain the fixator for some more time. But if the collapse is less than 2 mm, we remove the fixator. I have follow-ups for 12 years now. None of them has encountered a loss of correction. Yes, one patient has a varus, but that was purely my mistake. That was my second case. And I did some readjustment and did not take a full-length X-ray after readjustment. I believed on eyeballing, which was wrong from my part. Her high tibial osteotomy, her surgery has failed. That was not because of the fixator part. That was only because of my calculation error.
Okay.
Hi, Krishna, can I put a question to you?
Yeah.
So how do you basically counsel the patient for the predictability of the time duration that they might have before they get into a knee replacement, or can they really escape a knee replacement with an HTO?
I never say that they can escape a replacement with an HTO. So what we usually tell the patients is, in my hands, this has worked for a period of say 12 to 13 years. That is the longest follow-up I am having. And of course, in the center where I am trained, that is with Dr. Mangal, I have seen patients with much more longer follow-up period. So I try to counsel them with all these factors, tell them that this is not a substitute for knee replacement. You might need a replacement in future. This has worked good in my hands. So I would definitely try to get the alignment corrected, and you should get pain relief as well as return to activities without much of a trouble. There are, of course, patients who most of them comes to me after shopping at least 2 or 3 places where replacement was advised. A certain percentage of people stay back with me, and I try to show them my results. I show them usually the videos and all those things, and many gets convinced and do the surgery. I'm not able. I would say I'm not able to convince 100% of patients who come to me. Probably 20-30% gets convinced to high tibial osteotomy because the push for arthroplasty is that much.
One more
Perfectly
question.
answered. Thank you.
One more question. Have you seen any scientific reports or scientific results that after shifting the weight bearing force in the lateral compartment and lateral compartment gets degenerated? I have never encountered that thing.
Overcorrection leads to lateral compartment pain. That is one paper which I read this only when I was preparing for this particular talk. That I had shown in my presentation also. I can put that in the group if required. The only thing that they say is there is a increased incidence of lateral compartment pain. I didn't encounter any paper which said that lateral compartment degeneration increased.
Because most of the papers mentioned that the reason for failure is either recurrence of varus or undercorrection. Undercorrection and recurrence. If we have realigned very well, and then if, as you said, between 3 to 6 degree valgus, then it works very long, and none of the paper says that it degenerates lateral compartment cartilage.
Yes. No paper I have seen. I haven't seen a paper which says that failure due to lateral compartment arthritis.
Can I add something?
Yes, sir.
See, this question was asked to Dr. Koshino in a conference in Delhi. That will lateral compartment osteoarthritis occur when you do HTO by any method? The answer he gave was that it took 50 years for medial compartment to degenerate, and it will take another 50 years for lateral compartment to degenerate. So by that time, the patient would have lived his whole life.
Yeah, that question I have added, Dr. Ravi Mittal. I remember that. I asked to Koshino in the APOA conference.
Okay. So I think that's quite, we should learn from other experience also when we are thinking about this problem, that none of our pioneers who are doing this surgery for a very long time, they had this problem.
And of course, if we do a preservation surgery, it gives us many years, and which is so very important. So if there are no further questions, we move on to the next, and I'll request Dr. Thakkar to tell us about the types of osteotomies around the knee.
Yes, sir. I will start sharing now. Can you show the full screen sharing? Screen is visible to all?
Yes.
Okay. Thanks for giving opportunity to deliver a talk on types of osteotomy around knee, and very nice program arranged by Dr. Rastogi. And if we if we talk about types of osteotomy around knee, that means the osteotomy in the proximal tibia, either in the distal femur, or it can be combined, both femur and tibia. So how we will decide where to operate? As Dr. Krishna Kumar has already mentioned, that we should try to correct the deformity where it is, from where it is generating. For that, we must understand the basic angles of the distal femur and proximal tibia. So I will mention about the informed angles only. If we see that mechanical, if we see there is anatomical.
Sir, your slides are not seen.
Okay. I think I stopped sharing and then again.
Yes.
Yeah. Now can you see?
Yes.
Anatomical lateral distal femoral angle is 81 degree plus or minus 2. And that is normally we can remember 81 degree. Anatomical femorotibial angle should be 173 to 175 degree. That is the normal value. Anatomical medial proximal tibial angle is 87 degree. And this is not important, but we have to finish that anatomical lateral distal tibial angle is 89 degree. And if we think that was anatomical angles, now if we see the mechanical axis, then mechanical lateral distal femoral angle is 87. Sorry, these arrows showing wrong thing. It's somewhere here. Mechanical lateral distal femoral angle is 87. Mechanical medial tibial angle is also 87. So mechanical and anatomical angles remain same for the tibia. And again, mechanical lateral distal tibial angle that also remains same and is 89 degree. So before that, we have to perform the mechanical axis deviation. That is what we can say malalignment test. When there is a varus deformity, we have to measure the angle. If mechanical lateral distal femoral angle is 87 degree, more than 87 degree, then it is a femoral varus deformity. When there is a mechanical proximal tibial angle is less than 87, then it is a tibial varus deformity, and we should correct it in the tibia. If it is in the femoral varus, then we should correct in the femur. And the same thing for the valgus. If we are examining the valgus knee and if we are measuring the angles for the valgus knee, and if there is mechanical lateral distal femoral angle is less than 87, then there is a femoral valgus deformity. And if MPTA, mechanical MPTA is more than 87, then it's in the tibial valgus deformity, where we should, many times we encounter that both the bones are deformed, then we should correct in both the sides. So if we see the types of osteotomy around knee, our aim, already previous speakers has told that aim of osteotomy is to shift the weight-bearing axis in the healthier compartment, that is Fujisawa, near the Fujisawa point. No, we should remember that we should not do much overcorrection also. And there are, if we consider in the proximal tibia, there are two types of osteotomy is described. One is arch type, that is what we call is a dome osteotomy. Dome osteotomy with a concavity upwards and is also described, and one is the concavity downwards. So all these arch type of osteotomies was described by and was fixed with the Alizaro or external fixator. So for correction, we need some external fixator in arch type of osteotomy. And Dr. Milind Chaudhary has also described one osteotomy where fixator assisted internal fixator assisted dome osteotomy. And another is a wedge type osteotomy. Wedge type can be of two, open wedge and closed wedge. Open wedge we all are aware about and is very popular in a present era. Open wedge can be of three types. One is uniplanar, another is biplanar, and third one is tibial condylar valgus osteotomy. That is what we call as a TCVO. All three is very popular in present time. And open wedge has their own limitations. Each osteotomy has their own limitations. And another closed wedge is practicing since more than 50 years. That is closed wedge supratuberosity, that popularly known as Coventry osteotomy, and even closed wedge osteotomy, infratuberosity, that very commonly I am choosing the infratuberosity closed wedge osteotomy. And this osteotomy can be in the distal femur. Distal femur also, that can be open wedge or closed wedge. Open wedge again can be uniplanar or biplanar, like that. Now we will see each type of osteotomy with their limitations also. This is a one type of arch which I said that with concavity downwards, and it has to be corrected that, and this we can on table we can check correction by I think cautery cord test or like that. And here we can see that this concavity is upwards. So this is I think become not very popular because probably maybe the reasons I have not practiced this osteotomy anytime. So I cannot comment much about this, but there must be some technical issues or some expert skills may be required. This is not been replicated by most of the surgeons. Few are might have continued doing arch type of osteotomy, but it's not very popular. Now, in open wedge osteotomy, that is very popular. And before that, we have to plan how much degree we should open. The Miniaki method is a very common method and very particular method for preoperative planning. Here is shortly, I will show the Miniaki method. The first, we have to draw the mechanical line. Then we should draw a line. One represents the plan weight bearing line. And this plan weight bearing line passing through near the Fujisawa point. And then line 2, that is, it connects the hinge point, that is superior tibiofibular joint for the open wedge, and that hinge point to the center of the ankle joint. And line 3, that connects the osteotomy hinge point to the arc of intersection of line 1. So this is our correction angle. That is what we have measured, this alpha angle that is to be corrected. Then we can put a cut here. One cut is required for a uniplanar. For biplanar, it's another issues. And after cutting this, we have to, this much angle we should open. And this is how it is opened. And the weight bearing axis has been corrected. So the open wedge has many advantages. One thing is technically relatively simple as compared to closed wedge. Only one cut is required. And another thing, fibula does not require any intervention. These are the advantages, but disadvantages is that there is we cannot correct more than few degrees safely. It has been described up to the 20-degree correction, but it because two bone surfaces are not in contact with each other, so it takes little longer time to unite as compared to closed wedge. These are some limitations, and this open wedge can be fixed with either external fixator or can be fixed with the internal fixator like Tomofix, Fudu plate, and various other Otis plate and various types of plate has been described. So this is all about the uniplanar open wedge. And this is the one example of open wedge. Here we can see open. Some may put bone graft. There is again a debatable that whether we should put bone graft or not. And this is one example which I have operated. This is the preoperative and postoperative after correction of, that is a uniplanar high tibial osteotomy and fixed with the Tomofix. This is biplanar high tibial osteotomy. So biplanar, that means osteotomy is done in the two planes. This is one vertical plane and this is horizontal plane. And after that vertical, this bone remains in contact with each other. So it has also advantages. Advantages is that the vertical remains in touch with the bone. So it unites very early as compared to uniplanar. And disadvantage is that it technically becomes long procedure, and it creates some problem of fracture of tibial tuberosity or like that. So all procedures have their own advantages and disadvantages. And now another open wedge. Many surgeons now have started tibial condylar valgus osteotomy, in which the medial femoral condyle is osteotomized and is opened like this. Here we can see, and then is either fixed with the external fixator. Most of the time it is fixed with the internal fixation. Advantages is that it regains the congruity of the joint, knee joint. And then another thing is it has a limitations that it corrects, it cannot correct larger deformities. And probably I have not done any TCVO, but I think it must be technically difficult also. So these are the disadvantages. And closed wedge method. Now preoperative planning remains same for the closed wedge as we have seen in the open wedge. The hinge point will be different. Here is the same thing, but the hinge point remains on the medial side. That is the convex surface of the proximal tibia. That is the hinge point. And after this much angle has been measured, here we have to remove the wedge like this. And then after removing the wedge, it has to be closed like that. So it has an advantage that both the proximal and distal surface of the osteotomy remains in contact with each other. And another advantage is that it unites very fast as compared to open wedge. But disadvantages are there that it requires some intervention in the fibula, either fibular osteotomy, or so we may have to do something to the superior tibiofibular joint. And then and second thing, what happens, as Dr. Krishna Kumar has said, that if we perform a Coventry osteotomy, probably knee replacement surgeons face that it may become difficult to do knee replacement if it requires in future. So these are the disadvantage of closed wedge. Closed wedge, as I said, it can be a Coventry. We can see it's very longest duration has been about the Coventry first became very popular even before total knee replacement era. And Coventry also can give excellent results if it is done perfectly. Because here we can see that there was this was after 20 years follow-up of that patient, particularly it was operated very senior orthopedic surgeon of Ahmedabad, Dr. Prabodhem Desai, and his son came to me to have an osteotomy. So I took the x-rays of his father. He was operated by Dr. Prabodh Desai. And even at the end of 27 years, this was the picture, and he was walking without any pain and he had a full function. So it has a good results, but Coventry has a lot of disadvantages. Which disadvantages? One thing, the osteotomy is performed above the tibial tuberosity. So there is a very limited space available. So more than 15-degree varus cannot be corrected. Another thing, flexion deformity more than 10 degrees is not possible to correct. And a third thing is fixation problem. Nowadays, in present era, plaster for more than 6 weeks is not tolerated by patient, and even plaster cannot maintain the correction what we have achieved on table. So these are the disadvantages. So most of the cases were going into the varus again and failure of the high tibial osteotomy in Coventry. So it becomes Coventry osteotomy has lost their importance in and then total knee replacement came into the picture. So nowadays, Dr. Maheshwari from Gujarat, Jamnagar, has made one plate to fix the Coventry osteotomy very nicely, but the long-term follow-up is still we are awaiting. And the another infratuberosity closed wedge osteotomy, that is very, I am fan of doing the infratuberosity closed wedge osteotomy, is done at the level of just below the attachment of patellar tendon at the tuberosity, and then apex is in the metaphysis, base is in the diaphysis. And this is one patient which I have operated. The weight-bearing axis is very well corrected and shifted near the Fujisawa point. And here we can see that the patient can have a full function after high tibial osteotomy. All osteotomies can get this kind of good results, excellent results, not only this closed wedge, but if we do perfect, the aim is to correct the weight-bearing, is to shift the weight-bearing axis near the Fujisawa point. That is the a main key of success of any of the high tibial osteotomy, either open wedge or closed wedge. Here now if we see, there is a distal femoral osteotomy. This is a 65-year-old lady suffering from her knee pain on the both side, but pain was more on the right side. So here we can see that there is a lateral compartment arthritis. So here we have to perform the malalignment test. And if we see that LDFA is lateral distal femoral angle is 75, normal value is 81 degree. So all the deformity, most of the deformity is in the femur. MPTA is also 90 degree, is more than 10, its normal value is 87 plus or minus 3 degree. So here most of the deformity lies in the femur. So in this particular patient, valgus should be corrected in the femur. And this is how Miniaki method is also described to correct the femoral deformity. And here we have to consider like this. Here is the plan weight-bearing axis of the center of the femoral head. At present, it is here. Our plan is to shift the center of femoral head here. And this is the hinge point. So this is the angle of correction, what we should correct. It came 17 degree, 17 degree in this particular patient. We can remove the wedge from the medial side like this. 17-degree wedge has been removed and is fixed after closure of the wedge is fixed with the medial femoral locking plate like this. And if we see the preoperative weight-bearing axis and post-operative weight-bearing axis, the weight-bearing line is passing from the medial tibial spine, achieved little less than expected, but still patient is happy and is pain-free. But ideally it should be, I think ideally we should achieve little more correction. Lateral open wedge to correct the valgus deformity has also been described. That is also we did in one patient, and around 10 degree of the correction we achieved. We put a bone graft and fixed it like this. But medial open wedge of the distal femur, lateral open wedge for the distal femur again has the same disadvantages. What that the bone context is not in contact with each other. Bone surface is not in contact with each other. So it may take little longer time to unite. So even varus deformity also can be in the femur, or it is not all the time in the tibia, and valgus deformity is not all the time in the femur. So here there is again a method, Miniaki method, to measure the varus deformity in the femur. This is just a case which I am showing, just example I am showing. Here we can see that varus is in the femur because LDFH, lateral distal femoral angle, is 98 degree. The normal value is 81. So all the deformities is in the femur, and MPTA is 88. So it's near normal because normal value of MPTA is 87 degree. And here we should correct in the distal femur. So closed wedge osteotomy in the distal femur, lateral base closed wedge osteotomy in the distal femur is like this. And we can correct the deformity like this. So all these are the femoral osteotomies what in the distal femur to correct the either varus or valgus deformity. And here we can see the clinical picture also about correction of the distal varus deformity in the distal femur. So one more patient, combined HTO. Many times it requires combined high tibial osteotomy and distal femoral osteotomy also. Here, if we see here, there is a difference. This is non-weight bearing axis and this is weight bearing axis. There is opening of lateral joint space on weight bearing. So actual deformity is in the 10 degrees. So all the preoperative planning, what we should do is non-weight bearing full length X-ray, and then we should correct the deformity. Here we can see in non-weight bearing X-ray, LDFA is 87, the normal value is 81. MPTA is 83, normal value is 87. So deformity is in the both. Femur value is 81, normal value has been increased up to 87. So 6 degree varus in the femur and 4 degree varus in the tibia. So we should correct on the both side. So in tibia, we have to do some over correction also. So what I planned was that 8 degree correction was planned in the femur and 8 degree correction was in the tibia. Our aim was to achieve over correction 4 to 6 degrees. So here was the plan. After doing tibial osteotomy, I again take a full length X-ray, and then I see that the tibia was corrected less than as planned. So the 8 degree planning was converted into 10 degree correction in the distal femur. And after both distal femoral osteotomy and proximal tibial osteotomy, that is a closed wedge, both the closed wedge, distal femur and proximal tibia. And this is how we have shifted the weight bearing axis near the Fujisawa point. So the same thing can be done with the open wedge proximal tibial osteotomy. This is weight bearing X-ray of the same patient with both the closed wedge. Here we can see that there is no opening of lateral joint space on the weight bearing that was there previously. And this is again a combined osteotomy. Here we can see after doing high tibial osteotomy, little correction, even more correction is required. And then we did the lateral base closed wedge osteotomy in the distal femur. And this is the double osteotomy. And we have shifted the weight bearing axis satisfactorily in the near the Fujisawa point. So these are the various kind of osteotomies, and even there are many other methods has also been described, but most of the routinely practiced osteotomies which I have shown already to you. Thank you for kind attention. Thank you, sir.
Thank you, Dr. Thakkar. So if there are any questions,
Now, just one question. Have you ever found like you have been doing plates in majority of cases, right?
Yes, yes.
So once you have did it and take a weight bearing X-ray and you see that there is a slight over or under correction, what is the percentage of patients in which you have experienced that? Because you don't have the option of taking a weight bearing X-ray when you're doing a plate, right?
No, not weight bearing X-ray. It's a good question. When I am doing HTO since more than 20 years. So initially, I was not taking any thing during surgery, that whether it is overcorrected or undercorrected. So this problem I face in the initial phase, but at present, in every patient during surgery, I take a X-ray. Even I don't rely on the IITV images also. I take a X-ray in 14:17 cassette, and then I measure the MPTA, right? MPTA on table. On table, I measure the MPTA. Suppose I have targeted the MPTA that is 87. I want to bring it to the 94. Then I will measure on table that MPTA has come to the 94, which I want. Then I fix it permanently. Otherwise, it's a temporary fixation. So in
Okay,
that
so
way,
before plating, you take the X-ray, like
with temporary fixation.
Right.
Either one or two screw in the proximal fragment and 1 or 2 screw in the distal fragment. And then I take X-ray. And then is X-ray, I satisfied with the X-ray, either it is not overcorrected or not undercorrected, then and then I do permanent fixation. That is the only thing what I do, because as you said, once I come out of the theater, I can't do anything.
Dr. Thakkar, when you have to do both femoral and tibial, you do in one sitting or sequentially?
I have shown the 2 patients. Most of the time, if it is planned, then I try to do in both. And on table, I take full length X-ray to check that whether which exactly
in one
required.
sitting.
Yeah, one sitting. Only one patient I have operated in 2 sittings. Other patients, most of the patients are almost all the patients are operated in one sitting only. But I take, after doing one osteotomy, first I do in the tibia, then I take full length X-ray before starting in the femur. So suppose I have done a little bit under correction in the tibia, so I can compensate in the distal femur.
So in theater, how do you take full length X-ray?
Full length X-ray, we have a portable machine, and the operation theater table is we make it maximum down, and we have a cassette, very long cassette that contains 3 grid, and then we put below, and then we do painting and wrapping again, as we are doing in 2 surgeries. On table, we can manage to take not as perfect as in the department, but we can manage to measure the angles.
One thing I would like to add is like one of the advantages that we have felt while doing a distal femur osteotomy with a plate and tibial osteotomy with a fixator is that we can do that in one sitting itself, because we finish off the femur, and if at all a couple of degrees of here and there that can be adjusted in the tibia, because you are starting the distraction at a later stage. That is one slight advantage when you are doing a fixator.
In a fixator has many advantages, I think.
Yes.
Fixator has
no, when you're doing a dual osteotomy, that is one slight thing that we have felt to be
even doing a single osteotomy in the tibia, then
Yes.
also it has many advantages, but only disadvantages is compliance of the patient. That is the only thing. Obviously, there is some disadvantages of external fixator, because patient cannot take bath as a fixator is on. And another thing is that during night hours, if they want to turn in the bed, that is what patient has already described to me, that what problems they are facing with the fixator for 3 months. And if they want to turn in the bed, then also it creates a little bit problems. So all these routine problems of fixator is that, but I would say scientifically most perfect method is the fixator assisted high tibial osteotomy. But at the same time, patient should be ready for this inconvenience for 3 to 3.5 months. you have done many with fixators, so you have a better, if any
Yes,
other.
one thing that we allow the patient to take bath daily. We allow them to wash the fixator daily. That is one thing that we routinely do. Number two, the problem of turning around in the bed, yes, it's there because there is something extra on your leg, which many doesn't feel comfortable. That's definitely there.
And
Yes.
there is a one fear of some direct heat to the fixator to the patients. That is very small things, but still, because this era is of instant result, every patient wants. That is the only drawback of external fixator. Otherwise, technically, the fixator is the best method to do corrective osteotomy. I think we finished in very well in time.
Yes. There is one question from Dr. Sinha. The role of cosmetic limb lengthening surgery.
I think Dr. Krishna Kumar Elizaro.
I'm to be very frank, if a patient comes for a cosmetic lengthening, if it's proportionate, I would say I would try to tell them that surgery is not needed. It has got its own issues. Almost 100% cosmetic lengthenings that has come to me, I've been able to counsel them properly and send them back without having surgeries. If it's, yes, I have done lengthenings for achondroplasia patients. That is altogether a different ball game, because there you have adequate amount of muscles. The soft tissues are tuned to their original length, so lengthening is not a big thing there. But if you are proportionate, I would say cosmetic lengthening is not something which needs to be promoted, because it has got, I have seen patients who had peroneal nerve palsy, who had joint contractures and stiffness after cosmetic lengthening, because the soft tissues in their body are tuned to their actual length, so we are trying to stretch it too much. So my take is no for a cosmetic lengthening, if you are proportionate.
Is Dr. Mangal Parihar is with us? Dr. Mangal Parihar can answer this. So appears he is not there. So we have finished well in time. And I thank all the speakers who have agreed to and given their views to enlighten us. And I thank all of you and all the viewers who have joined this program. And the second webinar we'll plan later, and we'll let you know the dates and details, which will be demonstrating various techniques in more detail. Thank you, everyone.
Thank you.
Thank you,
Thank you,
sir.
sir.
Thank you, sir. Thank you.
you.
Thank you very much.
Thank you.
Thank you, sir.
Thank you.
Right. Mr. Rishi. Dr. Rishi, Dr. Hoda, Dr. Rijlani. Thank you very much if you are around.
I think we have to call him because stop recording particularly.
Yes. You have Rishi's number?
No, I don't have.
I have Rijlani's number. We have finished. There's nobody to stop recording and take our thanks. And I thank you for all your help, and share Mr. Rishi's number to me for future use. Thank you. So as we exit, things will close down.
Okay, thank you, sir.
Thank you very much, everybody.